Ok, પહેલાં એમ દુઆ કરીએ કે આખા મગાની ઉંમર દરાજને દરાજ કરે જેનો શુકર આપણે અદા કરીએ છીએ કોન્ફરન્સનું રિયાલિટી આપને નજરથી થઈ છે. So my thread to Loloa's talk is substance use in adults and kids in chronic pain. And you know, in 1980s, 1990s, there was a huge surge and effort by the medical community to keep. Okay. I won't be able to see this then. There was a huge call by medical community to include pain as the fifth vital sign. And as a consequence, a lot of the physicians started assessing pain and prescribing pain medications to the extent that it backfired. It was overly prescribed and it became quite an epidemic. To the point now we're trying to reverse this problem. We have some of the the most global challenges in prescription of narcotics, and U.S. leads this in the world. Not that we have any less pain or more pain than the rest of the world. There are primary care physicians who are number one prescribers of pain medications. And youth and adolescents are increasingly thought of coming under the influence of pain medications. So there are a number of challenges. And before I set my talk, I just want to give a definition of what chronic pain is. So pain can be classified as pain lasting for at least more than 3 months. It's prevalent it's more prevalent than any of the other disease states, any of the chronic disease states, heart disease, diabetes combined. And it's increasing prevalence over the last couple of decades. 20% of adults are affected, and 8% of adults have high-impact chronic pain, in which case they're really affected in their day-to-day activity, and they just pre-morbid from it. This leads to depression and anxiety, a lot of the psych problems that are seen concurrently with having pain. They have reduced quality of life, and the employment suffers. And this has reached a crisis point in which there is profound societal cost and emotional problems. So there are a number of ways to manage pain. There are all sorts of pains. There are 4 types of pains: nociceptive, neuropathic pain, there is functional pain, there's psychological pain. And there are a number of ways to deal with these pains. And it's more of a continuum. It's not one fits all. And nothing is better in this continuum than psychological and physical approaches. And you can go from a least invasive to a most invasive treatment of pain. And really there is not much of efficacy in the most invasive of treatment. The lesser treatment has probably more efficacious outcomes than the most invasive. Physical therapy is probably the most outstanding way to deal with pain, but there are other modalities, and each to its own restrictive methods. Topical medications, you can only go so far as to address pain. It's only a quarter-inch thickness of adhesives of Flector patch or lidocaine patch that can only be used in joint pains. For the most part, really, you just can't use these topical medications for any deeper pains. But then there are systemic medications that you can use then for much more generalized pains. And then, of course, you have the interventional techniques for spinal problems, for instance. So you could have epidural injections or intrathecal pumps. So there are, before going into the pharmacology, there are a lot of non-pharmacological options. And biofeedback is one of them, in which a lot of the work is done to measure vital signs and seeing their responses to alleviating some of this pain feedback. There is relaxation techniques like yoga, physical and occupational therapy, cognitive and behavioral strategies, and there is what's called a guided imagery. Really, it's an up-and-coming technique to help with certain syndromes like phantom limb pain or complex regional pain syndrome, and it just primes the somatosensory cortex and sets up a weird pain condition. It uses a mirror to move affected hand, and this resets the somatosensory cortex and relieves phantom pain. You have acupuncture. It works for the most part. A lot of the insurances cover it, and in fact, it's a lot more effective in certain instances than just allopathic medication. And then, of course, you have TENS, which is transcutaneous electrical nerve stimulation, which a lot of the pain management docs like to use. If we go to the pharmacotherapy, different agents can be used for different types of pain. So it's a multimodal approach, and you can use one of any combination of these pain treatments. And the reason for the multimodal analgesia is to combine different analgesic regimes that act in different mechanisms. Inflammatory, like your NSAIDs and ibuprofen. Neuropathic pain. For neuropathic pain, you could have Lyrica or gabapentin. Antidepressants like amitriptyline or doxepin. Muscle relaxants like your tizanidine and cyclobenzaprine. And of course, you have the opioids. And then, randomized trials have shown repeatedly that multimodal analgesia involving combination of these several medications at different receptors is associated with superior pain control and decreases opioid use with decrease in adverse events. Now, what are the risks? There are always risks and benefits in these kind of treatments. And not all medications should be selected on the basis of diagnosis of pain mechanisms and comorbidities. And only through H&P and the proper H&P and diagnostic testing could you analyze the risks and benefits of using certain medications over another. There are non-opioid drugs that carry significant risks. As we know, the NSAIDs group have a lot of the gastrointestinal and side effects. They do cause high blood pressure and they have been implicated in cardiovascular disease and chronic kidney disease. Tylenol has hepatotoxicity. And antidepressant and anti-seizure medications do have a tendency to sedate and present fall risks. So we fall on opioids if the non-opioids are not effective, and opioids can be used at acute times, but really there is zero evidence of their long-term efficacy due to their tolerance and dependency, since they have a whole host of other potential risks. And the reason for these opioids having such tolerance and dependency is because of the full activation of immune receptors in the CNS system. And this leads to increased hyperactivity, so hyperalgesia, leads to side effects such as sedation and respiratory depression, constipation and nausea, vomiting. And also, because it's a non-selective mu receptor activation, it triggers a reward pathway leading to risk of opioid use and sequelae of misuse, addiction, and respiratory depression and death. And this opioid use disorder and overdose, that's just the tip of the unwanted drug effects of opioids. And so because of these problems, there is a better way to manage pain, and along comes buprenorphine. And buprenorphine, some may know, some may not know, is different. It is underutilized and is overlooked for chronic pain. We are using this more and more in this setting because it is a DES Schedule III drug, in which case you can phone in and get refills. It's derived from a poppy opium alkaloid, thebaine, and its advantage over the opioid is that it's a mixed action and agonist-antagonist, meaning it has both properties of a good opioid and some of the negative effects of the opioids, such as respiratory depression, is lessened. They have unique pharmacodynamics and induce potent analgesia with fewer adverse effects than conventional opioids. And something unique about buprenorphine is that it has a unique ceiling effect, so that it reaches an effect on affecting pain. However, the respiratory depression is not as high as an opioid would have. So you have the effect of analgesia without the respiratory depression. So not to go too deep into the pharmacology of buprenorphine, but just briefly, it is a mixed action partial mu agonist. It activates, in fact, two signaling pathways. One is a G protein, which is implicated in analgesia, and another one is a beta arrestin, which translates to decreased side effects and inhibition of analgesia. And the lesser and the problem with, not so much a problem, but the advantage of this medication of the opioids is that it has end-of-dose withdrawal, less end-of-dose withdrawal pain, and that leads to a smoother transition, allowing peaceful night's sleep and doesn't wake the patient up. What opiates does is to have short half-lives, and then it wakes the patient up, and then you go back into sleep. So they waver back and forth. However, this medication actually gives you a smooth ride without end-of-dose withdrawal, and it tends to be tissue-specific and providing analgesia while limiting its euphoric and respiratory depression. And it has the mu agonist, but it has the delta and kappa antagonist, which really translates to lesser depression respiratory depression, sedation, and some of the side effects that you see in opioids, such as constipation and immunosuppression. And in fact, it may just potentiate some of the effects of antidepressant, anti-anxiolytic drugs with reduced suicidal tendencies. And advantages of buprenorphine over conventional opiates is that it avoids the GI tract. And there are several forms of this. Transdermal being a butrans patch. It's suitable for 80 morphine milliequivalents or less and is FDA approved for chronic and severe pain. There is the Belbuca film, which is a buccal film that is used for, again, chronic to severe pain, FDA approved, and it's for lesser than 160 morphine milliequivalents per daily use. And there is a sublingual one, which I tend to use for some of my patients. And again, it's this medication is actually FDA approved for opioid use disorder. People who've been on opioids for a long time, and you want to convert them over, transition over to something less potent. And this requires the DEAX license. So what kind of patients can be benefiting from these medications? A third of cancer patients report moderate to severe pain. And there are randomized controlled trials have demonstrated efficacy of buprenorphine in cancer pain. And in fact, this medication is as effective in Schedule II morphine, as effective as Schedule II morphine and oxycodone and fentanyl. For neuropathic pain, traditional opioids are less efficacious than for nociceptive pain, despite their frequent use anyway. So buprenorphine shows a distinct benefit in improving neuropathic pain. Older adults present a challenge, so they have more pain and treatment options are narrow with age due to their greater polypharmacy and comorbidities and slow metabolism and different pharmacokinetics and pharmacodynamics. And because buprenorphine is highly globulin bound, so because it is highly globulin bound, it has less reduced risk of drug-to-drug interactions. Yeah. And lastly, conventional opioids carry a risk of toxicity due to accumulation of active metabolites in the renal impairment, So patients who are on hemodialysis, for instance, can be on buprenorphine without having accumulation of metabolites in the liver and plasma. Because buprenorphine is associated with less sedation, there is less of a fracture risk. And probably it's probably stemming from patients being less dizzy. So all in all, I think chronic pain does present a challenge, and buprenorphine is has a unique mechanism of action which confers specific advantages over conventional opioids. Less respiratory depression, less fatal overdose risk, superior efficacy over pain, rapid onset with sublingual formulations. It has a long half-life, and clinical effect has less end-of-dose withdrawal effects and better sleep. There's less tolerance and hyperalgesia, great long-term efficacy, less euphoria, less of the abuse potential, and works with coexisting opioid use disorder. less side effects, greater tolerability, and Schedule 3 over the Schedule 2 drugs. That's it. Thank you.
Thank you, Dr. Campwala. I know there were a few questions before. I know we're running behind on schedule, so we're going to try and squeeze our discussion a little bit, but I don't want to have the discussion missed. Dr. Banwanti, I think you had something to say earlier.
I think I can ask later.
Okay. Was there something in the audience before?
She asked a few times about why don't we have these statistics, why don't we have these surveys, and then towards the end of your presentation you said we should do this. I'm not a medical doctor, but the way I see it at least is there's a lot of taboo about talking or asking about these things. So the question would be, how do you address that piece? Because once that piece goes away, I think your surveys will happen.
I mean, I think we can keep it anonymous. There are ways of performing anonymous surveys. I don't think we'll ever begin to say that it's okay to be using or abusing. I mean, haram cha, simple, right? But the idea is that we want to provide guidance to not just youth, if you think about it, even the adults. We want to provide guidance to even them for cessation. And I think we need to start a forum for conversation. Once we can start the conversation and it becomes common ground, then we can start to have some kind of, so it just, something needs to start. Ji. So we need to kick the parents out, sorry. Ji.
So when I have a child, 14-year-old, 16-year-old, and it's not about drugs, it's about all other things which they are not supposed to do. I thought that under 18, I can still tell parents. I just found out, even if the 14-year-old is having anything, doing anything, even drugs or anything, I cannot tell parents. It becomes really difficult to treat because the prescription is under mom's. You cannot go and get the prescription without the card and all those things. It's very hard how to do this, and some of the young kids are like, even 14-year-old are so old and they are so like they're taking care of themselves, but still they're dependent on their parents. Now, even calling the labs back that this result is positive, you cannot tell the parents. And it becomes very difficult for as a doctor to treat that patient when you know that he's doing wrong first, number one. Number two, we need to treat this. It took us a while for one thing. I'm just telling you, I don't know what everybody's doctor. He was a chlamydia positive. And he was a 14-year-old. And we didn't know how to treat this kid. And we are calling the parents, and yet we didn't know how to tell. And we keep telling, the child keeps telling, don't tell my mom, don't tell my dad. And I don't want them to know. And so and about these drug things, it's very hard, especially if the parents are not in the room, even if they tell you. And we want to send them to some place for rehab. The parents has to get involved. There is no way, unless we have to figure out, and it takes a long time to involve the parents into it, take their confidence. You know, I had a 13-year-old pregnant mom. I mean, how can I not tell mom that she's pregnant? I mean, it's a very difficult situation as a doctor, and as a parent, it's going to be more difficult.
And then imagine going to a daris that night at the parents' house. God forbid. But it is very difficult. It is very challenging. So what I do in those cases, I actually take the child, whenever I have an adolescent that comes in, I get their cell phone number. Yeah. It still shows up on their, yeah.
My comment was, as you said, just recently found out. I think we don't know. Do most families know that we have a responsibility to protect the confidentiality?
So I mentioned that at the beginning of the visit. Or I take the history with the parent present. most of the history. And then I mention, okay, I'd like you to step out for a few minutes, and anything that is discussed between your daughter or your son and myself will remain confidential unless I think three things. I need to get the cops involved, he's going to hurt himself, or he's going to hurt someone else. And so I make that very clear. And some parents are hesitant to leave the room. Why do I need to get out? My child's not doing anything. I don't ask the child, do you want me to have your mother or father step out? Because that puts the child in a very tricky position. Because whatever jawab they give, they might either, if they say yes, then there's an assumption that they're doing something. If they say no, then they may not confide in you. So I ask the parent to step out regardless. I mean, I'm not great at this all the time, 100%, but when I am doing it, I ask the parent to step out. And then I do get their phone number, and then we call them. Now, the hard part is that everything gets billed. On the EOB, it'll show up. So it's still not really, the law is there, but really it's not 100%. You have to just hope and pray the parent doesn't look at the EOB.
The most effective way of obtaining a history would be just getting a history from the child on his or her own, without the parent being there. Because that way, you have the trust of the child, and you and the child have a building rapport, and that's the best way of treating it. And to a certain extent, you don't have to mention everything on the medical records, because I think that's all open. But then next time, you have to, at some point, you have to write it. Yeah, right.
So there's another thing. Our facility at least has a lab joined with our facility, so we have our own lab. So I'll have them give a urine sample. Let's say if I want to do a urine PCR for a GCCT, I'll have them give a urine sample in my clinic. I'll test for pregnancy and then those two items. And then we'll have my nurse or MA send it over to the lab on their own, and then they can go get the rest of the blood work done separately.
I think there's one piece that we're missing here, though, and that is it's our responsibility to work with the children and to talk to them about how to speak with their parents. Because like you said, it's very hard to treat a child without their parents' involvement. And we have to be the bridge to communication. So when you talk to the kids privately, one of the hardest things is to convince them to bring their parents in. And so we talk about, being that resource for them, being the bridge for them, being the one who talks to their parents, telling them, I will help you get your parents involved, because that's how we're going to help the children, and that's how we're going to help parents help their children. Right? That's what a psychologist will do when you send them to get counseling. They'll do parent counseling. And I think that piece always has to be there, because that's going to make your job so much easier if you can get the parents to be a part of the conversation.
In fact, what is so apparent over the last couple of years from COVID is that you see kids being affected psychologically from being in the house and not being out and socializing, and that has had a tremendous impact on them, both academically, socially, and psychologically. And how do we address these? So that's a huge challenge. But I think talking to them and gaining their trust is the goal.
I'm going to thank our speakers again. I think this is a start of the discussion, but it doesn't end here, so thank you. We're going to take a short break. Please, apna schedule manjo. Next sessions, the one here is Women in Leadership. The one upstairs is Surgical Complications. Please take, and there's suturing and ultrasound workshops going on simultaneously. 5 minutes? Before 4:30.